All right, welcome back everybody. My name is David Boetigger. I'd just like to start by acknowledging the traditional owners of the land we're meeting on, the Budyari people, and pay my respects to their elders past and present, and emerging. So I prepared these slides with Virginia Wiseman, who's also from the Kirby Institute, and I'm going to be doing most of the talking. Virginia might chime in every now and then. So today I'm going to be talking about economic evaluation checklists and go over a case study as well, which was sent out a couple of days ago. Some of you might have had a chance to read it, but as Steve said, we'd be optimistically hoping for 50% of you to have read it. So I'm going to go over it in a fair bit of detail, so it doesn't matter if you haven't looked at that. All right, so the learning objectives. First, I'm going to describe the intent of economic evaluation reporting checklists, including CHEERS. I'll describe that acronym in a moment. I'm going to describe some of the items necessary for reporting an economic evaluation, explain how the quality appraisal of an economic evaluation is different from assessing the comprehensiveness of reporting, and then go over some of the strengths and weaknesses of economic evaluations. All right, so economic evaluations are on the rise. Compared to what was happening in the 70s and 80s, the number of economic evaluations being pumped out now is extraordinary. So between 2012 and 2016, there was an average of 1,200 economic evaluations being published per year. However, having said that, there's been a lack of consistency, or historically anyway, there's been a lack of consistency in the methodological and reporting standards for economic evaluation. So the rationale for using checklists is that the risk of making costly decisions due to poor reporting combined with a lack of mechanisms that promote accountability makes transparency in reporting economic evaluations especially important and a primary concern for journal editors and decision makers. So essentially, given the importance that economic evaluation holds in decision making, it's important to be transparent about what's actually going into those economic evaluations, especially for the decision makers. All right, so the CHEERS statement is an attempt to consolidate previous guidelines on reporting for economic evaluation. It's used, the checklist is used by a number of different groups. So this figure depicts it nicely. Up the top there, you've got researchers like myself who use this in their academic publications. Below in the yellow, for health technology analysts who are using economic evaluation to evaluate PBAC, MSAC submissions, and so forth. Students like yourself, it's a useful tool for learning about economic evaluation. We've got patient representatives who might be wanting to understand how economic evaluation is performed. And then also editors and peer reviewers. It's becoming increasingly important. In fact, a lot of journals now require, if you're submitting an economic evaluation publication, you need to submit that with a CHEERS checklist, showing that you've met all the criteria that's on that checklist. Now, it's also important to mention, and I was mentioning this to a few folks at lunchtime, that the CHEERS checklist, or the checklists that look at reporting, are slightly different to checklists that are focused on methodology. So there's other checklists for economic evaluation methodology, such as the second panel for cost effectiveness in health and medicine, Phillips checklist for modelling. So most of those are focused very specifically on the method that you're going to use for your economic evaluation. So I'm going to focus on the CHEERS checklist because it's sort of an overall assessment of what you need to include in an economic evaluation, or the important aspects, and obviously there's a lot of crossover with the methodological guidance. All right, so in summary, the purpose of the CHEERS checklist, or the Consolidated Health Economic Evaluation Reporting Standards, it was created to ensure health economic evaluations are identifiable, interpretable, and useful for decision making. It's intended as guidance to help authors report accurately which health interventions are being compared and in what context, how the evaluation was undertaken, what the findings were, and other details that may aid readers and reviewers in interpreting and using the study. All right, so let's dive right into what the CHEERS checklist is actually comprised of. So there are 28 items. The first 3 I've got up there are very straightforward, so as you'd expect in any sort of publication. The format is very much like an academic paper. So you've got your abstract, introduction, methods, results, discussion. Obviously you need a title, that's number 1, an abstract, an introduction. So they're fairly standard things. I'd be very surprised if your article didn't have those. Then going into the guts, I guess, if you like. Hopefully you can see this. If not, it'll be pretty clear in the slides that you'll be handed out. So item number 4 is having a health economic analysis plan. I think this is a fairly new one here. This is the CHEERS 2022 checklist is an update from a previous version, and there are a couple of things added in the most recent version. I believe the health economic analysis plan may be one of them. So firstly, having that plan, defining the study population. So this is like your table 1 in a typical epidemiological paper where you're describing your population. The setting and location, that's particularly important for economic evaluation. Obviously, you have different currencies, you have different settings where there's high income, low income, middle income, so forth. That's very important in this type of evaluation. The comparators, so all the speakers have pretty much talked about having a placebo or a status quo and comparing that to an intervention. Often you'll see multiple interventions as well, so it's important to describe those clearly. The perspective, so most of the presentations today have been talking about a health system perspective, so where you're just looking at medical costs. Another common perspective is the societal perspective, where you're taking into account some of the opportunity costs. So, for example, the cost of somebody coming to see the doctor, what opportunity cost is there to that, and putting a value on that. Including those is typically called a societal analysis, and that's something that some checklists recommend. Where are we up to? So time horizon. That's important to describe, especially in modelling studies, where you're looking over how long the study or your effects and costs are accumulating over. The discount rate that you're applying, as Joe and Rebecca talked about earlier as well. There are standards around that. Typically in Australia, you sort of use a value of between 3% and 7%. If you're just looking at a clinical trial where it's just sort of something happening over a very well-defined period of time, you may not use a discount rate, but it's just important to be explicit about that. The selection of outcomes, the valuation of outcomes, so how they're being valued, and then the measurement and valuation and resources and costs. They all sort of come under one group, I guess, of looking at outcomes. Good. Then got currency, price date. So it's important to state what currency you're talking about. It's also important. You may have seen in some papers on economic evaluation, they talk about something like 2012 US dollars or 2015 US dollars, and essentially that's that's taking into account inflation. So a 2015 US dollar is not going to buy you the same as a 2020 US dollar. They're not quite the same, so it's important to report that. The rationale and description of the model, so if you're doing a modelling study, so outlining the rationale behind that. The assumptions that you've used in your economic evaluation. Characterising heterogeneity, so whether your economic evaluation is slightly different or whether the costs and the benefits are different in subpopulations. Typically you do that in a scenario analysis. Characterising distributional effects, so you're seeing a lot of benefit in a small number of patients, or are you seeing a small benefit in a lot of patients. Characterising uncertainty, so this is then talking about sensitivity analyses. So, where are the key areas of uncertainty in your model or your evaluation, and how important are those uncertainties? And then finally, this is a new one on the 2022 CHEERS checklist, the approach to engagement with patients and others affected by the study. All right. there any questions about that, the methods aspect? No? All right, we're going to talk a bit more about that as we go into the case study and then also onto the group work. Okay, then moving on then to the results and discussion. So the first part of the results is typically describing the parameters that you've used in your model or your evaluation. You'd also typically present the ranges and references. So your base case and then the range that you've used for your sensitivity analysis. I'll give examples of that in a minute. Summary of the main results. So this is where you're presenting your ICEs. The effective uncertainty, so that could be your scenario analyses and also your sensitivity analyses, and then the effective engagement with patients and others affected by the study. I have to admit I've never used a checklist with that specific item, so that, like I said, this is a recent checklist and I'm not quite sure how you would articulate that, but something to think about. All right. Then a discussion, and then other relevant information, which would be in pretty much any type of publication, your sources of funding and your conflicts of interest. Okay, so all checklists share some common domains for appraising economic evaluations used in CHEERS. As I said, there's a lot of crossover between other checklists. I'm going to take you through a paper that looks at some of the details of the CHEERS checklist and those other checklists. Okay, so this case study is in an area of research that's quite close to what I do. It was conducted by my postdoc supervisors, actually, James Kahn and Elliot Marseille. I wasn't involved in it, so feel free to dig in and rip it apart if you notice any mistakes. But by and large, I think it's been pretty well done. Now, the title of that was Cost Effectiveness of Male Circumcision for HIV Prevention in a South African Setting. So just to give you some background, in 1990, there were ecological studies that showed in countries where males are circumcised, they were less affected by HIV. And so that led to observational work, and a meta-analysis in the year 2000 of 27 observational studies in sub-Saharan Africa found that there was reduced risk of HIV among circumcised men, with an effect size of 0.52 or a 48% reduction in the number of HIV cases. So in 2005, the first randomized clinical trial to look at this was conducted in Orange Farm in South Africa. And they found a similar risk reduction to what was shown in the meta-analysis. And so obviously we have an intervention here that looks like it's effective, but with limited funds available for HIV prevention in sub-Saharan Africa, it's important to consider the economic feasibility of implementing that intervention. And at the time, based on other interventions for HIV prevention, they were looking at a range of between $10 and $10,000 per HIV infection averted as being something that would be acceptable. As you'll note, that's very different to the £30,000 recommended by NICE and the $50,000 to $70,000 recommended by Australian, or not recommended, but implicit in Australian approvals. And essentially that's because we're talking about a low middle income setting. They have a smaller pot that they're taking from to fund interventions like this. Okay. So diving into the methods then, I like to use this PICO-HP acronym. You might notice PICO if you've done any sort of randomized trial work. So the population, the intervention, control, and the outcome. That's essential when essential core aspects of a clinical trial or any sort of comparison of interventions. For economic evaluation, we throw in the HP because it's important to also consider the time horizon that you're looking over and the perspective that you're focusing on. So health system perspective or a societal perspective. So in this particular study, the PICO-HP, so the population, we were looking at a cohort of 1,000 men from South Africa, from the South African general population. The intervention and control, so we were looking at circumcised men versus not circumcised. In terms of outcome, we looked at HIV infections averted and DALYs averted as well. So going back to what Joe and Rebecca were talking about, where we've got the cost utility and cost effectiveness studies, it's also possible to combine those two types of design. So here we're looking at cost effectiveness in that we've got a sort of a real world outcome, I guess, of HIV infections averted, and then also a calculated outcome of DALYs averted. The time horizon was looking over 20 years. We'll talk a bit more about that on slides coming up. And this was taken from a health system perspective, so just looking at direct program and medical costs. All right, so the costs were, obviously one of the main costs was the cost of circumcision. That was based on the main trial, so they took data on the cost of circumcision from the trial that was conducted before this economic evaluation. They also took into account the cost of adverse events from circumcision, and that was based on the frequency that were reported in the trial and the assumed management of those adverse events. They also had to consider the cost of HIV treatment, which was taken from a previous study. And then all costs were converted from Rand to US dollars. US dollars just seem to be more digestible by most readers, so that's quite common. At an exchange rate that was relevant at the time, and they were inflated to 2006 US dollars. This study was published in 2006. Okay. Now, looking at uncertainty and heterogeneity, I haven't. This slide doesn't cover all the ways they assessed uncertainty and heterogeneity in the study, but just some key examples. So the model assumes that it was a steady state epidemic, so the incidence of HIV wasn't going up or down. It was staying steady, but they did vary the incidence rate. So their base case assumption was 0.038. But they also looked at a minimum incidence of 0.028 and a maximum of 0.048. So that was one of the key ranges that was evaluated in their sensitivity analyses. They also looked at an alternative scenario where they were just focusing on young men, so looking at the cost effectiveness within young men, and also in a situation where there was poor coverage, so not many men were taking up the intervention or the circumcision. And they conducted multiple sensitivity analyses, so one-way sensitivity analysis where they would vary one parameter at a time and see what happened. Multi-way sensitivity analyses where they might vary 2 or 3 at one time and see what impact that has. And then also probabilistic sensitivity analyses where they're varying multiple parameters at a time within the sensitivity range and within a sort of probability distribution that was representative of that specific variable. All right. So these were the results. As we talked about with the CHEERS checklist, the table 1, this is showing their main parameters that went into the modelling work. So as you can see, the cost per male circumcision was one of the key costs. So that was $54, approximately $54 per circumcision, but they ranged that between $27 and $82, and that was based on the trial. They chose a population of 1,000 males. That could have been any number, but 1,000 allows them to calculate an average. I won't go through all of those, but essentially this is representing the key parameters that went into their model. It shows the range that those parameters were varied within, and you've got the reference there. So meeting all the criteria that's within the CHEERS checklist. All right, and then the most interesting results. So this is where the ISA is presented in table 2. So firstly, you've got the cost of male circumcision. So that came out at $54,000, which makes sense. They had $54 per circumcision. They circumcised 1,000 men, so $54,000 as the cost of circumcision. They estimated that the cost of managing adverse events would be just over $1,000. So combine those two costs, you get $55,754. They then looked at HIV infections averted, and so they reported the undiscounted value and also the discounted value. So that's taking into account what Rebecca was talking about earlier, where we tend to value things that are happening now rather than we tend to value things that are happening now more than things happening in the past, in the future. So when you apply that discounting rate, we see 308 infections averted. And so applying the cost of 55,000 to the number of infections averted gives an ISA of $181 per HIV infection averted. Now, I would argue that the more relevant value here is that that final one, which is actually negative $2.5 million. Because that's taking into account the savings from infections averted. So if people are not getting HIV, then obviously you don't have to treat them, and that's saving a lot of costs. All right. Yeah, go. Could you use the microphone?
When you use discounting there,
Yeah.
Are you taking into a time into that account? So it's at 5 years, is it 10 years? Like what is that discount for?
So the time horizon was 20 years on this. Yeah. So some of those infections might occur in their model sort of after 20 years from the time of the intervention, and they would be discounted back. Yeah. Right. So they also conducted exhaustive sensitivity analyses. So this figure on the left. So the different lines are looking at different parameters. The 50% is the base case, so that's why the cost per HIV infection averted there is 181. So that's your base case. I'm talking about. Is there a pointer on here? Yeah, there you go. A fly. Yeah. Oh right, an actual fly. Can I zap him? So this is your base case. So if you go across to the left, that's around about $181, which was the base case ISA. If we vary these parameters, so I find this scaling a bit odd, but if we increase the value of these parameters, these lines show what would happen to the ISA. And then if we decrease, you can see there's an impact on the ISA as well. Broadly speaking, though, this range of sort of between $100 and $400 is pretty small. So I would say that the impact of varying the parameters within their sensitivity ranges was not great. They also did a three-way sensitivity analysis where they varied 3 different parameters. They report the results of that. So this is important where you might sort of have, I guess, cumulative effects. So if you vary one parameter to its maximum sensitivity range and another parameter to its sensitivity range, that could be multiplicative, and you could have quite a large effect on the ISA. And there's not really any standard way of doing that. It's sort of based on what you think might have an effect. And then finally, they also did some probabilistic sensitivity analyses, and that's useful for getting your 95% confidence intervals. So this is where you're adjusting all parameters within your model within a particular range and distribution. And so when they did that, they found the range. They found their ISA varied between $95 and $427. And as I said before, I think the more relevant ISA is probably this bottom one. So they found that value of $2.4 million in savings varied between $0.9 million in savings to $4.3 million in savings. All right, I also mentioned that they did some scenario analyses. So when they performed male circumcision just in younger men, so between 18 and 24 years, they found that actually substantially improved cost effectiveness. And it appeared to be because it was averting the rise in prevalence that occurred through ongoing risk. they also looked at coverage and found that effect was small, and that's actually a fairly consistent study, consistent finding in a lot of studies where the impact of adherence essentially is quite small, because the people that are taking the intervention are still, they're the one that are incurring the costs because they're taking it and they're getting the benefit. The ones that don't take the intervention or use the intervention don't incur any costs and don't get any benefit, and so they essentially just don't contribute to the ISA. All right, so in conclusion, in settings in sub-Saharan Africa with high or moderate HIV prevalence among the general population, adult male circumcision is likely to be a cost-effective HIV prevention strategy, even when it has low coverage. Male circumcision generates large net savings after adjustment for reverted HIV medical costs. All right, is that a question? No.
Because the results were really only evident after 20 years. So how do you sort of account for that?
Yeah, so
or
it's
adjust for it, or?
Yeah, so I guess that's what the discounting is doing to some extent. So it's that idea that future benefits are brought back to what we would value now. But yeah, it's an interesting one. Obviously the benefits are there. If you're preventing HIV infection, that's obviously a good thing, even if it is over a long period of time. And I mean, it's important to mention also this is a modelling study, so it's not like they had to do this study over 20 years. It was a projection. But yeah, it's a good point. Things can change quite significantly within 20 years. Yeah. I mean, if there's a cure for HIV, then it sort of throws these results completely out of the water. Yeah.
Can I ask, that's just looking at the individual, so the guy not catching it, but this is an infection, so if they catch it, they pass it on to their partners, so it doesn't take into account. Does it? I don't know.
No, this model doesn't, because that's quite difficult to do. Because then where do you stop? Because that person doesn't get an infection. They don't infect anybody. The people that they infect don't infect anyone.
But you have, so illnesses have a certain infectivity rate. So, for example, if they had high levels of HIV treatment, they'd have undetectable viral loads, so they wouldn't pass it on. And so, I mean, I guess you can make you have to make assumptions around the rate of reinfection.
Yeah. Yeah.
It's tricky.
Yeah. So it's just difficult to model that out. Steve's got his hand up, so I'll let Steve say something.
I think in an ideal world you would build that in, but in a sense, if you were being pragmatic, this study doesn't need it. I mean, that will just probably add to the treatment effect here. A question similar to that is that it seems like the treatment effect is based on observational data, looking at the relative risk between the two groups.
It's based on the trial.
A trial, is it? Oh,
yeah.
Okay. Does that take into account, it's not related to the economics, but does it take into account the fact that people who may get circumcised then sort of adopt higher risk behaviours because they feel protected?
Yeah. I don't think they did account for that. Yeah.
Okay.
Yeah, but it's an important consideration. That reminds me of some of the work that's ongoing around PrEP, which prevents HIV, but also seems to create a bit of a behaviour of increased sexual activity, and it's quite impactful on the cost effectiveness of PrEP.
I've heard a similar thing around advanced driver training programs.
Right.
And,
they think they're an F1 driver.
Yeah. Create the opposite effect. Yeah.
Sorry, one more question. So going back to, I think in your introduction slide, of this study, you said that $10,000 to $10,000 was acceptable for per HIV infection avoided. But why is there a minimum number $10? Isn't like $3 better than 10? Do you know what I mean?
So I believe that was based on the sort of interventions that were being used in sub-Saharan Africa at the time. And as I said, you know, we're dealing with countries that don't have a very big health budget and so don't have a lot of money to contribute to prevention interventions like this. Yeah, sure. Obviously, you want the smaller, as small as possible. But that was just the range of interventions that were being approved at the time. So, yeah, they felt if they could get an ISA somewhere within that range, then that's likely to be something that would be accepted within countries that are going to use that intervention. Yeah. All right. So now we're going to go over to you guys. Going to break into small groups. I'm not quite sure how we're going to do that. So it can be within the tables, or you can break into, yeah, I think the tables make sense. Yeah. And discuss some questions about the study. So has anyone had a chance to actually look at the paper? Yeah. No. Would it be helpful if I gave you 10 minutes or so to sort of go over it? Do people want to do that, or do you want to launch straight into it? I'm getting a bit of a mixed response. Yeah. Okay. So we'll have 5 minutes to read through the paper, and then we'll go over 7 questions.
I did email you the paper, and the paper's also on that website, if you're looking for it.
opened as US levels. It's not too bad for the West Coast. Yeah, it's, they're so far behind, it's almost like 24 hours. I just think she has to work on Saturday. So was it a while ago then? 2018 to 2019, like the end of 2019, so just before COVID. Yeah. Yeah, it was weird to come back because I was at the Kirby Institute, then left, then come back, but then started working remotely straight away. So yeah, nobody knew I was back.
It seems like Kirby's not even properly back now.
They're struggling with that.
Kirby's pretty useful when it comes to that sort of thing. I noticed that in London as well. I think it was part of it because people used to use the not come. And in London, it's like
Find I can be quite productive at home. I do like to see people.
I hate it when
Yeah.
I mean, I end up doing more work at home because you think you can't take a break.
So at the moment I can literally see my desks on my bed, which I think is an awful lot. But like say it's so accessible, you're like, no, I'll just do this. All right, I think we'll get going. All right. How do you feel about it? Good? Not so good? All right, let's see. Okay. So I'm just going to go over a few questions to dig into the methodology and see what you think. So the first question is, do you think the study compares costs and outcomes of meaningful and appropriate options? And I'll throw open to the floor. Yes.
This was an imaginary group of 1,000 adult males.
Yep.
So I just quickly looked up, as one does on Mr. Google, and the major infectious diseases in this particular area, in this particular population, is malaria, TB and HIV. So we don't know if there's any comorbidity or other conditions occurring in that group at that particular time.
That's true. Yep. So do you feel as though the outcomes were inappropriate? Sorry?
Yeah.
Yep. Any other thoughts on the outcomes?
a lot of the HIV treatments do come with side effects to the patient. So including QALYs, would it have made any changes? I don't know.
Yeah, they did look at DALYs. Yeah.
Oh, okay. Sorry, I did.
I'm actually reading the question again and realising this is more about the options. So here we're talking about the intervention and the control. So do you think the options were appropriate? Yeah.
Just on one thing, it
Yes.
says the model assumes no direct benefit to female partners of circumcised men, and I couldn't see anything in there about male to male.
Mm. Yeah. It's probably showing that the date of the study, they probably didn't consider that at all. I'd say if they didn't look at male to female transition, they also didn't look at male to male transition. Yeah, transmission.
David, could I just make a comment about the intervention? So the intervention is circumcision per se, but I would have thought in terms of the policy option, it's I guess it's subsidy, some sort of government subsidy for circumcision. I mean, you're obviously not going to have a program of just sort of mandatory circumcision or whatever. It's got to be tied to some sort of policy, and from that point of view, you evaluate the cost and the impact from that perspective, don't you, rather than just circumcision per se. And I just wonder whether the study might have been framed more specifically around the policy option, like do we fully subsidise circumcision or we partially subsidise, we put it on, you know what I mean? There may be a more direct sort of policy link to this, to the way they frame the intervention.
Yeah, you felt like that was something they could have added.
I suspect so. If it was directed at a policymaker, I mean, you look at it and a policymaker would say, well, what do I do with this? You know, I know circumcision's cost effective, but how does that sort of, how does that help me in terms of making a decision about, you know, funding or policy or program delivery or that sort of thing?
Yeah. I guess they'd argue that it's just one element of a policy decision, so it's cost effective. Other aspects of this you need to be considered. Obviously, making a policy decision doesn't just rely on economic evidence. Yeah. I'd be curious though, do you think they could have thrown in other aspects of policy relevance to this
policy? I mean, they could have looked at different variations of a policy rollout of a circumcision-based program. So, one might be one that's targeting infants, one targeting adults, one might be based on a certain level of subsidy, another might be based on, I don't know, some other sort of variation in the way in which the delivery mechanism is rolled out.
Yeah. I guess they did look at that to some extent with the scenario analysis where they looked at just younger men. But yeah, they definitely could have been more exhaustive.
Isn't that just because that's what they were doing at the time? Because this is based on a few epidemiological studies that were looking at the efficacy of... Sorry. Thank you.
So is the reason that they didn't look at infant rollout, for example, is because this study is actually based on, the epidemiological studies that have been done in recent years looking at efficacy of circumcision to reduce transmission of HIV. So how could they do it on infants? Because it's not been done routinely, so it'd be quite difficult to model on that, wouldn't it?
Yeah.
Yeah.
That's a good point.
Yeah.
All right. So I felt like the interventions were appropriate. They were based around a clinical trial, so it was fairly obvious looking at status quo of doing nothing versus implementing male circumcision. And yeah, I thought that was fairly clearly presented. All right. So moving on to the second one. Does the study clearly justify its time horizon? There's a small bit of text in there that really answers this question well. So, did anyone find it? So the time horizon was 20 years. Yeah. Did you feel that was appropriate? And why?
Oh no, I don't know whether it's appropriate, but I agree 20 years is good. Well, 20 years is probably quite good because it gives time, doesn't it, to detect cases of HIV as well as longer term health costs associated with HIV treatment.
Yep. So this duration captures the persistent protective effect of male circumcision as well as delayed epidemic effects, which is exactly what you said, just in slightly different words. Yeah. I'd probably argue that they could have used longer. Often you see lifetime time horizons used. However, it was very cost effective and even cost saving when they took into account the costs of managing HIV infection. So the benefit of making a longer time horizon, it's only going to become more cost saving. So not really necessary to project longer than that. All right. How appropriate are the data sources? Anyone want to have a stab at that? Yeah.
The trial data is not that inclusive, therefore we're carrying non-inclusive data from the previous trials forward.
Non-inclusive, what do you mean by that?
So just going back to my earlier question, if we're not taking into the account female partners or male to male, you're carrying non-inclusive data forward into non-inclusive cost modelling.
Yep, that's a fair comment. So it's not really projecting out the extended benefit of the intervention.
But that, again, that works in favour of the intervention, presumably. I don't know, do we know?
Yeah, so presumably if they'd looked at the benefit of stopping transmissions, it would only be more cost effective, which I think Steve alluded to earlier.
Can't you only project from who's in the trial anyway? If the original trial they didn't look at onward transmission, like non-small, for example, you don't have that data to use anyway, right?
So even if it wasn't collected directly, they could make assumptions and model transmission rates and so forth. Yeah, so you can definitely do that. It's just a far more complex model, which is probably why they didn't do it. Yeah. So can you use the mic?
I might not be looking at the right place, but specific cost inputs were male circumcision during, so many acronyms, sorry. So it looks like they got, that their data was the reasonable kind of data to use to make these model out of.
I agree. Yep. So all the input values were shown in Table 1, and I thought they were presented clearly. They showed the ranges that they varied those parameters within, and they also cited where that information came from. So a lot of it came from the trial, but they also used outside sources or other published literature. Yep. All right. Were the outcomes appropriately measured? Anyone want to have a stab? So what were the outcomes?
Is it the effectiveness with the super long equation, the number newly circumcised times 1 plus 1 in that paragraph? I think it might not very appropriate because it seems very arbitrary to me. There's no citation for that. Why I believe this is not the first study to evaluate the effectiveness of HIV infection, but there's no. Apparently, the whole paragraph is not. It has no references, which is really suspicious to me.
So which paragraph was it?
The effectiveness, the methods, page 2352.
Does it mention the outcomes?
Is it the effectiveness, the equation? Is it the outcome?
So I'm not sure which equation you're looking at.
Under effectiveness, sorry.
Yeah, this one.
The bottom of the first paragraph.
Is that the outcome?
No.
You don't think so?
I don't know. No, that's just the what looking at in terms of protective effect of the circumcision.
I'm not sure what it's calculating.
That's just looking at the effectiveness of circumcision, I think. But on the outcomes that are looking at male circumcision and HIV infections, and then survival from HIV infections, and they're appropriate.
So circumcision would be the intervention.
Intervention, sorry, yeah.
Yeah. And the outcomes you mentioned.
HIV infection.
Yeah. And there was one more.
And cost of treatment.
Yeah. So.
I'm trying to remember. I didn't read it recently.
Yeah. So all of that would go into the cost. There was one other outcome. Yep. So that was the main one for sure. There was one other secondary. HIV infection averted. So there were lots of other things that went into the evaluating the final cost, so including the cost of adverse events. But that's on the cost side of the ISA equation, thinking about effectiveness. And remember I mentioned that this was a combined cost effectiveness, cost utility analysis. Yeah, DALYs. Yeah, yeah. So HIV infections averted, which I think is appropriate, and also DALYs. And they also talked about how they calculated DALYs, which is fairly crude. So we calculated DALYs by the reduction. We calculated the reduction in DALYs for HIV by multiplying HIV infections averted by previously reported discounted DALY changes with ART and without. So 21 DALYs if you're... So they assumed that with ART you would avert 10 DALYs, without you would avert 21 DALYs. And that's assuming that 50% of patients were on ART, remembering this is in 2006, so not everyone was on antiretroviral therapy. And so then putting those numbers together, they came out with a typical number of DALYs. I think it was around 15 DALYs. A patient would lose 15 DALYs if they were infected with HIV. I did just want to mention the importance of including DALYs. So one of the benefits of using QALYs or DALYs is that you can compare it across other studies and other interventions. So looking at HIV infections averted is obviously very important for this study, but if I want to compare male circumcision with a completely different intervention that prevents something else, let's say something that prevents TB, how do I compare the cost effectiveness when something's preventing HIV infections versus something that prevents TB infections? It's difficult to make that comparison. You're sort of comparing apples and oranges. If you use DALYs, then that creates that similarity. So you can compare different types of interventions across different fields. So it's quite important to include a QALY or DALY as one of your outcomes, in my opinion. Yeah. All right. What about bias? How did they account for bias? Yeah. I guess so, yeah. I mean, it helps. Yeah. I mean, you typically try and pick your parameter value that you believe is most accurate and unbiased and all that. But varying that is always makes sense. But that would typically be classed under sort of accounting for uncertainty as opposed to bias. Yeah.
I guess because it's a theoretical model, it's not an empirical, it's not an observational study, we'd be looking for biases in the assumptions that we set up.
Yeah. Yeah, I'd agree with that. There was just a couple of things that I thought were good inclusions. So they accounted for adverse events. Sometimes you'll see economic evaluations that don't account for adverse events, and obviously that's sort of biasing towards favouring the intervention because it's not taking into account all the potential harms of that intervention. They also used a long time horizon, and we touched on this earlier, that accounts for the delayed benefit of the intervention. So obviously when somebody has a male circumcision, the benefit immediately is very small, but over a period of 20 years or longer, that benefit accumulates. So it was important that they included that time horizon, otherwise they wouldn't have seen much benefit. Their results would have been biased towards showing no benefit, or poor cost effectiveness. All right. How transparent were the authors? So this is a fairly straightforward one. Anyone want to have a go at this one? I think it's there on the first page somewhere. Yep.
Can you just say?
Yeah.
Just,
And
Sorry,
they also
there's no competing interests on the first page, and they are funded by National Institute on Drug Abuse, which is probably not conflicted with circumcision.
Probably not, yeah. But if it is, they've declared it anyway. That's the important thing. Yeah.
It does seem like a pretty straightforward question, doesn't it? But it's actually a really important thing to look out for, especially in the world of big pharma, and looking very carefully at who's actually funded the economic evaluation. It's a very important question, and just because it's published perhaps in a reputable journal or one that you recognise, you can, if you go and Google, perhaps when you get home, and look at some of the cases that have come up for the big journals like Lancet and others, where a conflict of interest has been exposed later on. It's I mean, I wouldn't say it's frequent, but it happens. So it's and it has a big impact, I think, on the way you interpret these results sometimes. Steve, I think.
I think it's also important to recognise that conflicts of interest aren't always commercial, and often some of the strongest conflicts I've come across involve people evaluating their own programs, and I guess some of you may be in that position in future as well. So it's important to be transparent about that, and So I don't know how that you get around that, but it's important to recognise that, if you're running a program, you've also got a very strong interest in making it effective and cost effective.
All right. One more comment? Yep.
It's not, well, it's a little bit about bias, but what would you say about there not being any African people or African institutions listed as authors, and the aspect of co-design? I know it's just it's a thing. It's not necessarily make you discount the findings.
Yeah. That's a really big topic now. In 2006, it certainly wasn't. But yeah, I'm sure there were African people involved in the study, in the design. To what extent I couldn't say, and I think it is a weakness of the study for sure. Yeah, I think it's really important to have that local input, just for added context. Yeah, you never quite know if you're answering the right question or not taking into account some important issues if you haven't got local people providing input. Yeah, thanks for that. All right. And the final question, and probably the most... Oh, yep.
I was just going to come into this last question. In their findings, they say cost effectiveness improves by less than 10% when male circumcision has a coverage of 50%. But when you look at what the average coverage is, it says it's 35%. So are they kind of...
Is that average coverage like without any intervention?
Yeah. So it says in 2002, Human Science Research Council study found that 35% of South African adults and young males had been circumcised.
Yeah.
So
sorry, go ahead.
Just how do they get, like, how do they account for that?
Yeah, so the intervention is male circumcision, so you can obviously only circumcise men who are not circumcised. So this is a study that would be done amongst the 65% who are not circumcised. So it's evaluating the cost effectiveness in that population. And then the modelling work has assumed that we've circumcised all of those men. And you get a cost effectiveness value for that. Obviously that's an ideal setting and that's probably not going to be possible. So that's why they looked at coverage. So achieving 50% coverage amongst that 65% of uncircumcised men is a scenario they looked at. And as I mentioned as I was going, you can think of that as adherence. So when you're performing the intervention only amongst those people who are receiving it, even if it's a smaller coverage. So only that group is incurring costs and they're the only ones that are getting benefits from it. The ones who choose not to be circumcised, they're not incurring any costs. They're also not incurring any benefits. So they don't really affect the cost effectiveness equation. Yeah, so it's a very consistent finding across studies that adherence doesn't really impact cost effectiveness. Yeah. It would, however, impact the budget impact.
Yeah. Okay, thank you.
Yeah.
So, So regarding the involvement of the South African peoples, in the acknowledgement, they have acknowledged that South African Center for Epidemiological Modeling and Analysis. So they have acknowledged them. So for the analysis purpose, so South African people are involved.
Okay.
Yeah.
Good to know. There's definitely a push for papers like this that are conducted in low middle income countries to have local representation on the authorship list as well. All right, final question, question 7. Probably the most important question. I should have put this first. So is the significance of the results for policy discussed? And if so, where? I can give you a hint, it's usually at the end.
It's on the last page in the blue box.
Yep.
Why was this study done?
What does it say?
So it says getting this information is crucial before health policy makers can decide what strategies for preventing HIV are most appropriate for their country.
Yep. So I think there was a bit more as well where they've sort of projected a bit further than that. So I think this is at the end of the discussion. Can't remember. But they also talk about some of the specific countries that might benefit who currently have a low prevalence of male circumcision but a high HIV prevalence. So these results could potentially be very relevant to those countries. Yeah. Virginia.
Thanks, David. I guess one of the things that I'd ask everyone to consider is if you were the Minister for Health or maybe the Minister for Finance and, you had this evidence, I can imagine that the first thing you might say is, well, I am doing something. We have got a condom program. We've got this, this and this. It's not like we're doing nothing. So to some extent, you kind of wonder, in terms of the policy relevance, is it a missed opportunity? Maybe there are other programs, and I guess it's just to raise that whenever you're designing these, you do have to have a very, clear conversation with the people running the programs or those in the Ministry of Health about what is our comparator and is it do nothing, or are we comparing it to something else you're actually trying to do to target this particular group? Because I suspect they would say, we do stuff already, quite a bit.
Yep. Yep, fair point. Sorry?
I'm assuming they're in that setting because they gave the cost for those interventions. Whether it was discussed with the Minister of Finances. Because I agree.
Yeah, I guess the comparator.
Oh, you mean a comparison in the actual evaluation? Yeah.
Sorry, yeah, not the
Sorry. Yes, just to clarify, I was saying for the original design of the economic evaluation, what you're comparing, what policy options or intervention options you're comparing. And one of them is nothing, basically, versus this. Yeah.
I just had a question, sort of building on from that, thinking about the application of this to a project that we're looking within my hospital setting. If the intervention includes the intervention plus alternate or other models of or treatment or therapy for people who perhaps don't want that therapy. So, for example, I'm thinking of remote patient monitoring patients outside of the hospital setting, which is accessible to patients who have data, have phones, want to be monitored, are technology literate. But as part of that, we're thinking about interventions for patients who don't have access and perhaps don't want that intervention. So in terms of evaluating, the impact of the whole model of care rather than an individual or, a one type of therapy, how do you go about that?
So, if I understand correctly, you're sort of talking about things that would be ongoing.
Yeah. So it's ongoing. It's it's not a option A or option or current status. It's basically we're introducing brand new monitoring or models of care for patient cohorts, and there might be multiple options in terms of what patients might be able to access as part of that.
So how would you do that? Yeah. So I mean, you can certainly add more arms to your economic evaluation. It doesn't have to be control versus intervention. You can have control versus intervention 1, 2, 3, 4, as many as you want. I don't think we go into it in this course, but you then talk about incremental cost effectiveness. Where you're comparing two interventions that might be cost effective, and you need to figure out whether one that's better and more expensive, whether that is cost effective compared to another intervention that is also cost effective compared to, say, status quo or doing nothing. That's slightly more complex, but it's the same sort of principle where you're evaluating one versus another. And that's where those thresholds sort of come into account. You can get to a point where it's difficult for the intervention might improve upon another intervention, but it comes at such a cost that it's not worth doing that. So even though it's a more effective intervention, it's not cost effective to use that. Even if you were comparing it to status quo, it might be cost effective and you would want to do it. But if there's another intervention that is very effective but slightly less effective and doesn't cost as much, then you'd probably go with that one as a decision maker. It's I've heard the comparison of like comparing your Corolla to your Ferrari. If you want something to go A to B, getting there in a Corolla is probably just as good as having a Ferrari, but you don't really need the Ferrari. Yeah. All right. Any more comments? I think we have some time for just general discussion. Were there any more questions?
I didn't want to jump in if there's someone else who is wanting to speak. No? Okay. I wanted to come back to the point that David made about appropriate outcomes and appropriate costs being measured. And one of the ones that we've heard a bit about today is the resource savings. So in this case, we talked about cases of HIV averted. And it's really important, but it's also quite debatable, or there can be some controversy around resource savings. And I just thought it might be worth highlighting with an example. So just in my area where I've been working in malaria, malaria rapid tests can be quite effective at averting malaria cases, test and then direct people to treatment. So the people that test positive get treatment. And so you can calculate all those cases of malaria that have been averted and put a dollar value on that. But what we also see is that people perhaps that travel a long way to a health service, they expect something. They've come with something. They don't perhaps feel that well. It's not malaria, so they are given quite often antibiotics. So when rapid tests for malaria were introduced, antibiotic use went up quite dramatically in lots of settings. And people have then been trying to do things like measure the impact on antimicrobial resistance. I think this comes back to a point that you raised earlier, maybe about these sort of broader impacts. So, in that situation, you could calculate all the resource savings from malaria cases averted, but at the same time, you've got these complex behaviour changes that are going on where people are actually consuming more antibiotics. Some people may need them, some people may not. Might get overuse, driving antimicrobial resistance. So you can imagine these models are getting and I think that's what David was sort of alluding to before. It can quickly spiral a bit out of control because you really have so many things going on. So resource savings are important, but in some situations, you've just got to, I think, be a bit cautious as well. Cautious. Oh, there's a... Yeah. Mm-hmm.
All right.
Are we got time for another question, or are we moving on?
Yeah, no, go.
I've got a question about, I get at what we've read, this looks like a really effective and great value program, but unless I've kind of missed it over the last few years, it doesn't look like something that's been rolled out. And I'm wondering if you can answer, firstly, if that is something that's been taken up, and if it hasn't, what potential? Because it's all really great to come up with the economic benefit, but I guess there's the flow on from that of how you spread that message and then get the uptake. So can you give us your thoughts and insight and answer if it's actually been taken up?
I can't give you a very detailed answer, but it's definitely been taken up. So male circumcision is something that happens far more commonly now than it used to as a result of these studies. It's something that's recommended by the World Health Organization. So it's been a well accepted intervention. I couldn't give you exact numbers on where it's been well taken up and where it hasn't, and why not if it hasn't been taken up. But yeah, it's this research was impactful. Yeah.
The fact that it was taken up is probably puts it in the unusual category in terms of economic evaluations, because the evidence I mean, there have been reviews done about the uptake of economic evaluations that have been published, and generally speaking, it's a pretty disappointing picture. But one area where, the impact of economic evaluations has been promoted in recent years is through health technology assessment. And that's because it's embedded into the policy-making process. So it's almost sort of made decision-making tied to an economic evaluation, and it's happening in Australia, happens in UK, and increasingly in low and middle income countries where governments are rolling out social insurance programs. And in order for new drugs or new medical procedures to get into a social insurance program, that's increasingly being recognised that it has to go through a HTA process of doing cost effectiveness analysis. I mean, if we're just relying on economic evaluations that get published in BMC, Health Services, or even the Lancet or whatever, the picture is going to be pretty disappointing. Policymakers are going to just pick and choose the programs that they want, and they see the cost effectiveness and they say, oh, okay, that supports what I wanted to do. Unless there's a sort of a mandatory process where you're almost sort of obliged to take with the good with the bad, that's when you see real impact in terms of cost effectiveness evidence.
It is coming up to 20 years since this article was published, and so is there any evaluation of how predictive and how close to reality
that's a good question.
It was?
I don't know. I would doubt it. Yeah. Yeah, because it might be wrong. Yeah.
That's a very confronting question.
Can you wait for a microphone, Richard? Yeah.
It does happen quite often in the HTA space that once something is subsidised, we'll then go back and look at, well, they'll look at two things. Is it as effective and therefore cost effective as we thought? And is it being used as much as we thought it was going to be used? And they're really important questions. The question of cost effectiveness post-use is really challenging for a number of reasons. Two main ones is technologies aren't often used in the same way that we would anticipate they'd be used in a clinical trial. Something happens in clinical practice, patients are very different, and therefore we get very different outcomes and cost data. The other is that there's always new technologies, so that the way that we treat patients and the capacity to attribute benefit to something that's currently in use changes. So while we might do a lovely analysis like this, once practice changes, attributing health outcomes to this particular intervention becomes very, very challenging. Yeah.
Any other thoughts? Virginia.
Interesting papers that have compared the RCT trial-based economic evaluation results with real-world implementation. So there's one that was published recently on syphilis testing. I'm sorry, because all my examples are from low middle-income countries, but there's one about the testing of a syphilis testing for pregnant women, and it had a few sort of training elements to it as well. It was shown to be really cost effective, and the team that published, they then went back a couple of years after it had been rolled out nationally, and lo and behold, huge divergence between the cost effectiveness results from the original pilot to the national rollout. And this was, the things that have been touched on today. It's the uptake of the intervention. It's all the health system constraints. So, running out of the procurement system couldn't handle that level of, And then there were some positive things like purchasing large quantities actually drove down some costs at the national level. But overwhelmingly, the effectiveness was driven down and the costs were pushed up. So, yeah, it's...
Designing implementation science trials
Yeah, right. Uh-huh. Yeah. Yeah, it's a great question.
Yeah, it's not just economic evaluations. Yeah, randomised control trials rarely produce evidence that's then replicated in real life.
All right. We've got about 15 minutes. I'll wrap these up, and then if there's no more questions, we can go through the CHEERS checklist of this study, just to show you how the study did. All right, so the key messages: economic evaluations need to be rigorous, transparent regarding methods, and conducted ethically. Guidelines and checklists for economic evaluations can aid readers and reviewers in interpretation and use of the study. They can aid interested researchers in replicating research findings. They can help standardise and increase transparency in reporting. Promoting good practice is likely to improve evidence uptake and make stronger investment decisions. Caution though, checklists have different purposes and audiences, so even something that adheres to a checklist perfectly may not be a perfect study. Got a few useful references here, so you can click on these links from the slides. Also some further guidelines and checklists that you can check out. All right, we'll just go through the CHEERS checklist applied to the case study that we just looked at. It's a bit unfair applying a 2022 checklist to a 2006 study, but let's see how it went anyway. So first three, pretty easy to tick off. Did they have a health economic analysis plan? Well, they might have done, but they didn't talk about it, so across there. Study population, yep, they had 1,000 men from South African general population. The setting and location, so South African men, generalised HIV epidemic. Their comparators were circumcised versus not. The perspective was a direct program and medical cost, so health system perspective. The time horizon, as we talked about, is 20 years. And they gave good reason for including that or using that time horizon. The discount rate, we didn't touch on that, but they used a discount rate of 3% annually, which is pretty standard. Selection of outcomes. So they used HIV infections averted as their primary outcome, and they also looked at DALYs, and I explained the importance of using DALYs to compare across other studies in different sort of therapeutic areas. Measurement of the outcome was modelled. The valuation of the outcomes, so it was based on the calculated HIV incidence in South Africa, quality of life assumptions, and the trial effect for the effect of male circumcision. Measurement and valuation of resources and costs, so that was based on data collected in the trial and also assumptions that they made on adverse events and the cost of HIV care and also the management of adverse events. The currency, they used Rand, but they converted that to USD using an exchange rate that was relevant at the time, and they inflated it to 2006 US dollars. I've got in brackets there, or possibly 2003 US dollars, because I think they actually mentioned both in the paper, and it's not clear which. You'll often see economic evaluations use a particular cost, so they might use 2003 US dollars, and then these things can take a long time to get published. So by the time they get published, it could be 3 years on, and a reviewer will say, well, can you update your costs? Which is really annoying as a researcher, but yeah, something that happens, and that could be what happened here. Rationale and description of models, so they said their model's available on request. It was 20 years ago, so I think you'd probably have a hard time getting it now, but anyway. Analytics and assumptions, so they described the assumptions that they made. They did perform scenario analysis, so that was somewhat addressing heterogeneity, although as Steve mentioned, that they possibly could have looked at a few different scenarios which would have made it potentially more policy relevant. Characterising distributional effects, so describing whether the effects were sort of mainly seen in a smaller group of people or sort of distributed across the whole population. They didn't really look at that. Although you'd have to assume that a huge proportion of the benefit would be amongst those who didn't get HIV, which is a fairly small group of the 1,000 men. Characterising uncertainty, so they performed extensive sensitivity analyses. So tick for that. Approach to engagement with patients and others affected by the study, so they didn't do that at all. And like I said, that's a fairly new addition to the CHEERS checklist. Study parameters were shown in Table 1, the ICEs were shown in Table 2, the effects of uncertainty were explained in a lot of the figures and tables. They didn't talk about engagement with patients and others affected by the study or the effect of that. And they did have a discussion showing the limitations and study findings. And they did describe the sources of funding and conflicts of interest. That's it. Of course you can. We've still got a bit of time. Sorry, I could have done that.
So it just occurred to me, because I didn't explicitly state the perspective they were coming from in the paper, but obviously it's health systems perspective, but then they looked at DALYs, and I'm just wondering why you'd look at DALYs if it's health system perspective, because aren't DALYs a disability adjusted life years? That's particular to that person. I always thought that you would only do that, or QALYs if you're doing a cost, if you're doing something maybe from a societal perspective.
Yeah. You're right, they didn't explicitly say that it was a health system perspective, but you can sort of glean that from what they've said. The question about DALYs, DALYs are still relevant, even though it is a calculated outcome, not something they would have observed directly. It's still relevant.
Yeah. I'm wondering just to split, sorry if it's a stupid question, but I'm just wondering if it's from the health system perspective, what's the benefit of calculating DALYs? And I can see why you calculate them to compare across different studies, but if it's from a health system perspective, you wouldn't normally calculate DALYs necessarily, would you? Because it's that disability is not necessarily going to impact on the health system. I guess it would, but maybe I'm overthinking it.
Yeah, I'd definitely say it would impact the health system. If you're...
I guess it's just really hard to quantify, isn't it? Because it depends on what type of disability it is.
Yeah, you're certainly not calculating DALYs in your clinics, but if you can avoid people coming in for whatever it is, that's a positive thing.
Yeah, okay. Thank you.